everyone. Mega online course in anesthesia will continue the successful program by today lectures that presented by two figures in pain and intensive care. But let me first to express my happiness and gratitude for allowing me to participate in this wonderful and voluntary work. It's been a pleasure being a moderator for those great colleagues who are gonna present today lectures. I wish that participants get the most out of this training course, asking God to reward all those in charge of this honorable work of Egyptian Anesthesia Society. Special greeting and appreciation, recognition for Dr. Sam Mahdi's efforts. His efforts are bringing that work to reality. But before presenting our lectures, I would like to ask everyone to have mercy on all the martyrs from doctors and to stand mourning for their pure soul for a minute silence. ممكن أستأذن كل زمايلنا اللي مشاركين معانا في الميجا أونلاين إن يشاركونا بدقيقة حداد على أرواح الشهداء من الأطباء اللي فقدناهم نتيجة COVID-19 pandemic. 1 minute from now. Thanks, everyone. I would like to present our first lecture will be presented by Dr. Ahmed Kafafy. And Dr. Ahmed Kafafy, a known figure in pain medicine, he is a consultant in pain medicine, clinical service lead for pain therapists and NSK, Royal Orthopedic Hospital, NHS, Brigham Hospital. Today's lecture will be under the title of Opioid for Chronic Non-Cancer Pain. Thanks, Dr. Ahmed Kafafy, and waiting for informative knowledge from your lecture. The second lecture, our second lecture will be presented by Dr. Yasser Zaghloul, and he will continue enriching and updating our knowledge in ICU and critically ill patients. Dr. Zaghloul delivered more than 200 lectures in international anesthesia, pain, and ICU conferences. Dr. Yasser Zaghloul, consultant of anesthesia, Sheikh Khalifa Medical City, Abu Dhabi, United Arab Emirates, director of Abu Dhabi Anesthesia Club, lecturer and instructors of many international and anesthesia courses. Today's lecture of Dr. Yasser will be titled under the title of Cardiovascular Support in Critically Ill COVID-19 Patients. Warm welcome to Dr. Ahmed Kafafy, and we are all listening to your interested lecture.
Thank you very much, Dr. Warda Ali. Thank you for the nice introduction. Following from what we started 2 weeks ago, this is the third lecture in a row about chronic pain. These lectures are very important specifically for people entering the exam, fellowship exams, whether these exams are in the UK, in Ireland, or in other places. Clinically, they are important, but more to people who live in Europe and USA and things, because opioids are not very widely used for non-cancer pain in our home countries, in Egypt and in the Middle East and in many other places. It's not a long lecture, it's quite a short lecture, so please, if you can prepare some questions during the lecture, and I will hopefully have time at the end to answer these questions. It's I'm going to explain some bullet points, a summary of what's happening in the field of opioids around the world. What is the problems that are happening now within the opioid pandemic, which is in many places in the world. So I'm sure many of you will know this picture. It's a very famous old Hollywood movie. It's a very long one though. It's called The Good and the Bad and the Ugly. Very well known even in Egypt. Back home, I remember watching this movie with my dad many years ago. It's a very long one as well, 4 hours. So we found that the opioid combine all the three characters. So this movie is about three men, the good and a bad and the ugly one. The opioid combines all things in one medicine. And we will discuss this in details. The size of the issue. There is an issue around the whole world, which I'm sure everyone in the field of pain medicine, especially, and also anesthetics, know about it. A brief story about the problem. What happened? Why is opioid now everyone is speaking about? In the United States, in many years ago, especially in the late 80s, early 90s, people started prescribing more opioids. And of course, money is involved in everything, especially in the United States, where the pharma companies have very big influence on people. So the pharma companies started coming up with new drugs of opioids, such as oxycodone, hydromorphine, some synthetic opioids, not natural opioids. And they started advertising these with clinicians, with doctors, paying money, asking them to speak about these drugs, how effective they are. They did lots of research, but unfortunately, we found that many of these research were biased. So they showed that the opioids do not cause addiction. You can use them easily. They will not cause any harm. So doctors started prescribing opioids very widely for many people. They even put opioid as the fifth vital sign. We will discuss, sorry, they put pain as the fifth vital sign, just in order to prescribe opioids freely. So it's a massive problem in the United States. We're going to speak about it. In 2018, they announced a pandemic, a national pandemic in the whole country, because more than 140 patients were dying every day in the United States from opioid overdose. And so I was in the United States back in November last year, and everyone is speaking about it. They were even describing case reports of people dying now. So they stopped prescribing it now since 2018 to most patients. Patients started dying from a different problem, from the withdrawal symptom. So they have a big crisis, and it's very difficult to control. What about the United Kingdom? The situation is not as bad. We do have a problem. We're dealing with patients on very high doses of opioids. We're trying to reduce them, but it's not as bad as the United States, because the medicine in the United Kingdom is more evidence-based medicine. And it's different from many different places. So we have to look into the evidence very strongly before putting any drug on the hospital formulary. And I spoke about this in details last week. So what are we going to speak about today? Opioids and how they work. We discussed the mechanism before. We're going to discuss it briefly today. Difference between different drugs, routes of administration, how the doses compare. Very important. Why are they good? And we're going to speak about the good and the bad and the ugly. Why each one of these? What's the good practice in prescribing opioids? The most important from this that I want you to take is the resources at the end. I'm going to put some links of resources, which I want you, please, if you're interested in the subject, because I know that some people are doing some postgraduate studies like PhD and things on opioids. So please take these resources and read more at the end, because there's no time to speak about the whole topic, which is really big. Opiate, opioids, and endorphins. Are there any difference between these three expressions? Sometimes we get confused. Is opiates the same as opioids? What about endorphins? Okay, so opiate is actually comes from this. This is a flower. It's called the opium, or the opium poppy, they call it. And natural opioid medications and substances are extracted from this flower. If you use it in the natural form, it's an opiate, such as morphine, such as codeine, even heroin, which is a drug that we use widely in the UK. It's called diamorphine. Is also an opiate rather than an opioid. So, and then after that, the term opioid came around 15, 20 years ago, and it's a broader definition, because opioid means any substance that works at the level of an opioid receptor in the body. So any drug or substance that works on opioid receptor is considered an opioid. So every opiate is an opioid, but not every opioid is an opiate, if that makes sense. So it's a wider definition. Opioids include synthetic and natural opioids. Synthetic opioids such as oxycodone, such as fentanyl, which are, manufactured, or, they're done, they all come up from the lab, as you can see from the picture. What about endorphins? Endorphins are the naturally released opiates in our body. So as a result of stress or exercise, our body releases endorphins from the brain, and they cause very similar effects to opioids. They are painkillers, and they also help with the mood. So a picture of a chocolate, which something, if you love the chocolate so much, like many people, it will release endorphins in your body. Sites of actions of opioids and how they work. In the old days, many years ago, we thought that opioids work only centrally at the level of the brain and the spinal cord. And they work on certain types of receptors called mu receptors, or we call them also opioid receptors. We can speak for 2 lectures about mechanism of action of opioids and the proteins, the G proteins, but it's not within this lecture today. So opioids specifically work on the descending inhibitory pathway, as you can see. It stimulates the descending inhibitory pathway. Yeah, it stimulates the release of inhibitory neurotransmitters at the level of the dorsal horn, as we mentioned in my first lecture 2 weeks ago. It works their central action. I'm going to start with the quiz, which is usually, you find it at the end of the lecture, but I just want to refresh our knowledge of the opioid doses, because this is very important to know this. Sometimes we get confused. There are different types of opioid drugs. What about the doses of these drugs? Is a fentanyl different from a codeine, different from Zomorph? So Zomorph is a trade name of a it's a morphine. Only morphine, modified release morphine used in the UK is called Zomorph. So if you think about this, we've got 3 patients. One of them, the patient number 1, he takes 8 tablets of cocodamol, and cocodamol is a mixture of codeine and paracetamol in 1 tablet. So he takes 8 tablets of 30 milligrams codeine a day. So 3 times 8 is so it's 240 milligrams of codeine a day. What is this equivalent to morphine? Fentanyl 25 microgram patch, which looks like a very small dose, because fentanyl starts by 12, that's the smallest dose you can apply, and then 25 comes after this. What is this equivalent to morphine? 2 Zomorph a day, so 40 milligrams a day. What is this equivalent to morphine? Why do I want to bring an opioid back to morphine? This is very, very important. When you prescribe opioid to a patient, you need to bring any type of synthetic steroids to the equivalent dose of morphine before prescribing. And also on conversion. Many of the patients that will come to your clinic, for example, are on fentanyl or on oxycodone, and it's not working, and you want to convert this to another type of morphine. You have to bring the medicine back to the equivalent morphine dose. So morphine is the mother, is the base. You have to bring every opioid dose back to a morphine dose before prescribing, before escalating, and before converting from one drug to another. You will be surprised now when you see the figures. So 8 tablets of codeine a day, 30 milligram, which is the maximum tablet dose we have. Okay, do you know how much this is equivalent to morphine? 36 milligrams of morphine a day, the whole day. Not a big dose. What about fentanyl? 25 mics. Maybe you will think 25 mics of fentanyl is nothing because, you know, it's a small dose. We have 100 mics of fentanyl. Do you know how much is this equivalent to morphine? When you bring it back to the morphine equivalents, it's 80 to 134 milligram. We usually put it as an average of 100. So you times 4. 25 times 4 is 100. 50 mic of morphine is equivalent to 200 of morphine. This is a lot. I will tell you now that what's the maximum dose that you should be giving of morphine every day. 2 Zomorph a day, 40 is equal to 40 because it's the base of morphine. I hope that makes sense. So dose comparison, this is very important, as I said. So how do opioids compare to each other? in terms of the doses and their potency. The potency is, so the more potent the drug, the lower the dose you give from the drug to give the similar effect. Yeah. So for example, oxycodone is twice potent as oral morphine equivalent. 10 milligram of oxycodone, as you can see in the table, is equivalent to 20 of morphine. Dihydrocodeine is the weakest form of opioid we have. It's 10 times less potent than morphine. 10 milligrams equivalent to 1 of morphine. Codeine is like 6 times, yes? So you divide by 6 in order to get the, so it's around 4.5 or 5 milligrams, codeine phosphate. This is the one that is in the cocodamol. Tramadol, 50 milligram of tramadol is equivalent to around 10 of morphine. You need to know that as well. Diamorph, oxycodone, they all work in the same way. Butrans is a Butrans patch or buprenorphine. Butrans is the trade name of a drug called buprenorphine. This is a partial agonist opioid, one of the partial agonists, because it doesn't bind completely to the opioid receptors. Yeah, so the morphine binds avidly. It covers all the receptors. The Butrans doesn't do that. That's why it's a lot safer. So a partial agonist is always, the patient will be less tendent to develop tolerance, addiction, dependence from the opioids. That's why it's one of the early drugs that we like to start patients on, Butrans or buprenorphine. A 5 microgram an hour, it's a patch. I'm sure it's available in Egypt because I know many people that use it regularly. 5 mics of Butrans is equivalent to 10 milligram a day of morphine. So that's also a small dose. You can go up with the buprenorphine to very high doses. And as I said, because it's safe, now it's used in many rehab centers to help in addiction treatment, in withdrawing people off heroin, high doses of morphine. Buprenorphine can be used for this. Fentanyl patch, in my experience, is the worst ever opioid that you can give in patients, especially because of the very high tendency of dependence and addiction. We struggle to get people off fentanyl. Yeah. My colleague, Dr. Makins, did a big study on comparing fentanyl, oxycodone. I forgot to mention her at the beginning of my lecture. This lecture was prepared mainly for medical students as part of an FRCA program. If you're doing an FRCA exam in anesthetics, or if you're doing a fellowship in pain, you will have to be asked about opioids, especially these days. So it's very important. So me and Helen both had special interest in this. Helen now has a subspecialty clinic only to withdraw patients of opioids. So as I said, fentanyl is the last resort of drug that we would ever think of giving to any patient. I'm speaking about chronic pain, not acute pain. And this will come in details after this. So the good, we said it's the good, it's the bad, and it's the ugly at the same time. Why is it the good? Opioids are very, very effective in acute pain. They are good in terminal illness. They are good, as I said, as a fifth vital sign. I'm going to explain what's the fifth vital sign. Can you imagine that the United States in 2001, they decided to add opioids as a fifth vital sign. So, and this is mainly to be able to use it more. So if a nurse is passing on a patient in the ward, for example, and she measures blood pressure, temperature, heart rate, respiratory rate, these are the other 4 vital signs. And then she asks him about the pain. What's your pain out of 10? And he says 9. She will give him 10 milligrams of morphine. How can you put pain as a vital sign when pain is very subjective? It's not objective. You can't measure pain. You can measure the blood pressure and the respiratory rate, but you can't measure pain. So they decided now in 2016, after all the crisis, to remove pain as being the fifth vital sign. Yeah. So as I said, it's very good in acute pain. So please give opioids generously after surgeries because they can be very, very effective. And they can stop, even there is evidence they can prevent acute pain from becoming chronic. And unfortunately, in our countries, this wasn't happening, at least when I left, like in 2007. I remember my wife in 2005 having a cholecystectomy, laparoscopic cholecystectomy, and the anesthetist gave her 30 milligrams of pethidine after the surgery. She was crying of pain, and he said, I can't give her more than this because it's dangerous. Because that's the concept about opioids for acute pain, and unfortunately in many countries. I'm sure this has changed now. But she was in pain for like 3 or 4 days after the operation, just because she didn't get enough opioids after surgery. The risk of complication, there is evidence that medical complications can increase, especially wound infections, if the pain was not controlled properly after operation. So acute pain, that's why it's very good. And also in terminal illness, You don't worry about addiction or long term because you know the patient will not survive for a long time. So in the United States in the late 80s and the early 90s, they raised the profile of pain. They put it as a fifth vital sign, as you said. Look at this name, look up this name, Russell Portnoy. Russell Portnoy is a very well-known neurology consultant in the United States. This man, I have to mention his name. I don't mean anything and to say any bad things about him, but he's in the news everywhere in the United States because he was one of the reasons of this epidemic that is happening in the US, because he had bonds with big pharma companies and they started advertising to oxycodone specifically as a new drug that came in the United States in the late 80s. And he did some studies and he proved to everyone there is no addiction and the addiction is less than 1% from oxycodone. And it started to be used everywhere. They would use it as Smarties, you know, M&M's tablet. They were giving it to everyone with pain. So they started convincing people that we need to treat the pain aggressively. People can't live in pain. Let's give him opioids. Opioids are the magic pill. Oxycodone is the magic pill. They need to function. They need to have better quality of life. But when the pain becomes chronic, we spoke that it's very good in pain, but what is the pain chronic? Chronic pain is pain beyond 3 to 6 months. That's a chronic pain. There is no evidence that it helps much. And especially above a dose of 120 milligram of equivalent dose. So do you imagine 25 mics of fentanyl is equivalent to 120? So this should be the maximum dose a patient with chronic pain on. And this is the advice from the British Pain Society, depending on evidence. The benefits of opioids definitely reduce with time. Every patient with opioid will develop tolerance, and I will explain what tolerance is. So we found that some patients, they remain stable, but I would say that's a small group. They remain the same. The pain is better, and the same with the same dose of opioids. But we found that most patients need more. And also, we found that many of these patients actually will be better if we stop the opioids. And I will explain why is this. Tolerance means that when you increase the dose, that the dose of the drug always needs to be increased by time. The body adapts to the medicine. The receptors become completely saturated. The mechanism of tolerance is not very well known. It's all theoretical. If you look at the graph on the upper left of this picture, the upper left part, you will find that when you give the opioids at the beginning, they're always as a magic pill, as they would describe it. Very, very effective. They take all the pain away for a few days, up to a month only, with the same dose. So if I start the patient with 10 milligram morphine twice a day, slow release, he will say, doctor, my pain is 90% better, only for a month. And then it will become 70% better. And then after 60 months, as you can see from the graph, it will go down to 40 and 50%. After 12 months, it will be 30%. And then the problems will start from 6 to 12 months, many long-term problems that we will speak about. As you can see from the graph below that when you increase the tolerance, but this is the pharmacodynamic part. The pharmacokinetic part at the level of receptors doesn't change much because, as I said, most opioids are pure agonists. They bind avidly to the mu receptor. If you look below that, the tolerance, the more the tolerance increase, the less the effect of the drug. We're also aware of that. Okay, what about the bad? We said that it's good and bad and ugly. What's about the bad problem of opioids? Why are they bad? Dependence and addiction. Do we have differences? Do you know the difference between dependence and addiction? It's very important. This is one of the exam's questions. One of my case studies in my fellowship exam was about a patient on very high dose of opioids, and it also involved some psychological problems and things, but they asked me in details about how do you know that he's dependent on the drug? How do you know he's addicted? How will you treat this and approach this? So this is an exam question. Dependence is a physical symptom. And I will give you examples in the slide after that. So withdrawal symptoms is a sign of dependence. Headache is a sign of dependence. Tachycardia, when you stop the medicine, is a sign of dependence. Yeah. So physical symptoms. But addiction is actually when biochemical changes start happening in the brain after a long time with opioids, and then the patient starts experiencing behavioral changes. So a behavioral change is a sign of addiction, craving to the drug. The patient wants to have the drug by any means, even if he will cause harm to himself or to his family. A patient can reach a stage that he can kill a family member. He can steal money from a family member just to get the medicine. This is addiction. which is completely different from dependence. So as you can see in the picture, addiction is when the patient's behavior changes. He started to be obsessed. Yeah, social changes. He started to commit crimes, legal issues, denies everyone, saying to him, you know, this drug is harmful to you. He doesn't care. He doesn't listen to you. But dependence, which we see in most of our patients, is when your body is used dependent on the drug. If you stop it, his hand becomes shaky. He starts having tremors. He feels sick. He gets headaches, muscle aches. He becomes severe anxiety. Addiction actually is a late stage after dependence, which happens if you leave the patient on high doses of opioids. The reality of addiction, I'm going to tell you that in 2011, a study was done in Pennsylvania, which is one of the big states in the USA, and they found that the whole United States population are 5% of the whole world. Okay, and then 75% of all opioid prescriptions in the world were done in the USA. Can you imagine that? And that's all because of the propaganda that happens. It's because they trusted people. So we learn a lot from this. Anyone who gives us information about a medicine, we need the evidence. I'm not going to believe you if you say, I like this drug. Give me the evidence. Why is this drug effective? Why do you want me to use it a lot with the patients? So many, many years, people believed in these opioids, but now they are in crisis in the USA. Yeah, the incidence of addiction is 35%. And I'm speaking about addiction, not dependence. Dependence is far higher. 70% of people on opioids become dependent, especially if the dose is above 120, as we said, which is the maximum recommended dose. They found that the addiction is similar to the smoking and drinking alcohol. And that was all very recent. Only a few years ago, they found these things. The risk factors, this is very important, very, very important. Can all people become addicted the same? If you have a patient in clinic, can you start one patient on opioids and you say no to another patient? Yes, definitely. A very good history taking of your patient before deciding opioid is important, especially family history and social history. If a patient comes to my clinic and says, doctor, I was just recovering from alcohol addiction and I came back from an alcohol institute, and please give me some morphine. I'm not going to give him morphine because addictive personality is something that exists. Yeah. If he's got family history, if a family member at his household is addicted to medicine or opioids, if you give him the drug, even if he don't abuse it, if he doesn't misuse it or abuse it, his family, his member of staff will abuse it. So you need to be very careful with that. Yeah. Okay. What else makes the addiction more? Drugs that have rapid onset of action. So we have a very popular drug in the UK used for acute pain. It's called oral morphine. It's morphine in the form of liquid. It's a very quickly acting drug. It peaks up in the blood very quickly, and then it declines after that. They found that addiction are more with short-acting medication. You can reduce the risk of addiction by using modified release, long-acting drugs, and always have a plan. We're going to discuss that. Always have a contract between you and the patient, a signed contract. I'm going to use this drug with you for a short time until you get better, and then we'll have to stop it. If it didn't work, you have to stop it. The side effects of opioids. I'm not going to speak in details about this because we're all anesthetists. You know that opioids, even for acute pain, can cause constipation, can cause nausea, can makes a patient drowsy, can cause respiratory depression, especially if with other drugs, sedating drugs. But what we knew recently are the long-term problems with opioids. Opioids cause severe depression and anxiety. People who are on opioids for a long time will have severe mood fluctuations, severe anxiety. The picture down left, opioids not only cause weight gain because of patient being lazy or anything, but they found very interesting studies linking high dose opioid intake and sugar craving. And they found that the sugar works also on the opioid receptors, and they cause massive craving to sugars, people on opioids. I have patients who put on double their weight, but that was 10 years ago. Doubled their weight after taking opioids for 1 to 2 years. Can you imagine this? So this is one of the long-term problems of opioids that was discovered recently. Opioids affect the immune system, and that's also by evidence. So it reduces the immunity in the body, increases risk of infections, and also potential risk of cancers as well. It affects the bone and it increases the risks of osteoporosis on the long term. And also very importantly in men, it massively affects the endocrine system. And we see that a lot in clinic. So it affects the sexual function. If you're giving it in a younger adult, it causes lots of problem from the endocrine perspective. Opioid-induced hyperalgesia, it was something theoretical before, but we see it a lot in clinic. We see it a lot in clinic. It's something that we knew about a long time ago. As anesthetist, you probably see it from remifentanil, which is common with remifentanil, but also we see it with all types of opioids. And then also the very important sign that we'll see in the patient is hypersensitivity. So I'll tell you, if a patient comes to you in clinic on high doses of opioids, always test him for hypersensitivity. Just touch his back. If he's a patient of back pain or his neck pain, just touch his back or neck and he will jump. And this sign of hypersensitivity is one of the signs of opioid-induced hyperalgesia. And do you know how can you treat that? Reduce his opioid, and you will find the difference. The patient gets better if he has got this problem. One of the side effects we see these days. Prescription. How do I prescribe opioids? We agreed that we don't like opioids for chronic pain. We will prescribe it if we have to for a short term. Small quantities, more frequent. So you need to see the patient more if you give opioids. So in my clinic, I see the patient every 3 or 4 months. If I give him opioid, I see him every 3 to 4 weeks. Try and start the opioids only on a per-end basis. Just a rule of thumb for all chronic pain practitioners. Chronic pain is never constant. Even if the patient comes and tells you, my pain is very, very bad 24/7, this is not true. The pain varies. Patients will have good days and bad days. Patients will have days that they can't leave their bed, and they will have other days that they don't even need to take the painkillers. So PRN medication, especially on pure painkillers, which is when you need, is better than to take the drug on a regular basis. And it reduces also incidence of tolerance, dependence. I have patients who take the morphine once or twice a day only, because they say, doctor, I go shopping once or twice a day and I have to walk, and I like to walk for a mile to the supermarket. So I take my oral opioid, it helps me to walk and come back. This is perfect. If the patient will do this, this is what you want. So try on a PRN basis first and see. Drug choice, as we said, do you remember when we said about buprenorphine, a partial agonist? Always start with something like this, a partial agonist. Then move to a safer full agonist, like a Zomorph, which is a slow release, modified release morphine sulfate. Then maybe consider something stronger, like tapentadol. Tapentadol is in the US, in the UK, it's widely used now in many places. A very, very effective opioids, and studies show that also it's less, they develop less tolerance and addiction from it. We described this drug, if you remember, in the neuropathic pain lecture last week. So start by the safest opioids and then go step by step. SMART goals. Please remember this, SMART. SMART stands for specific, measurable, achievable, realistic, and time-bound. If you remember this, your patient will get the best result from the opioids. Specific. So what goals? Why do we need to put? We put goals with all our patients in clinic, because chronic pain is not treatable. Our clinic is called pain management clinic, not pain relief, because you can't relieve chronic pain is like diabetes, is like heart disease or hypertension. The patient will take the tablet most of his life and he will live with it most of his life. But you want to give him the best lifestyle, the best quality of life. So you need to be specific with the goals. So we start speaking with the patient. Why, if your pain goes away or gets better, what do you want to do? He says, some people say, oh, I have a big garden, doctor, and I want to be able to do my garden. I love gardening. I want to be able to carry my grandchildren. Many of them, I have a grandchild that I can't even lift up. I would love to do this. I want to be able to walk only for half a kilometer to my supermarket. So you have to have specific roles, okay? You can't put in the notes, the patient wants to have his pain relieved, or the patient wants his pain to get better. No, I wouldn't prescribe an opioid for a patient who's telling me this. No, you need to be specific. What do you want? What do you want to achieve? The pain you have is stopping you from achieving. It has to be measurable. And when I say measurable, I mean measurable. So 200 meters, he comes after 3 months. Are you able to walk 300 now? Are you able to walk 400 now? You go with the patient step by step, and we measure our goals. Achievable. If a patient that has been in pain for 20 years, come and tell me, please give me something, doctor, to be able to run a marathon. I will tell him, I can't help you with this. You have degenerative changes in your spine. And I show him his MRI scan, and I show him all the problems in his spine. I can't cure this. I can make you better, but you can't run a marathon. So he needs to be achievable. It needs to be something that he can do. It needs to be realistic as well. What do you want to do? He can't tell me, you know, I want to play football and be like Mo Salah, for example. It's not possible, because you've been in pain for years and years, and you can't suddenly be pain-free. You have to be realistic. Time-bound is also very important, because you have to put a time frame to the patient. We will give you opioids for the next 6 months, and then we will monitor. And you have to have a plan B. If it didn't help, we will reduce them and stop them. Why is it ugly? It's ugly because it kills. That's why it's ugly. Opioid, morphine, can kill. More than 100,000 Americans had accidental overdose of prescribed opioids, and that's only up until 2018. It's the second most common cause of death and accidental death in the US. And it's not only because of overdose, it's because of combined analgesics. You need to be very careful with this, because patients who take opioids also sometimes take diazepam, benzodiazepine. They also take neuromodulators like pregabalin or gabapentin. Combining all these drugs together is the one that causes the respiratory depression, which is the most common cause of death from overdose opioids. So why do we have a problem? Why do we reach this level? Because the patient have expectation, and the doctors also thinking of something completely different. The patient is very distressed. He can't move. He can't do anything. He tried, he had injections and had everything, and it's not working. And so he's requesting, and you've exhausted the BNF. Sorry, the BNF is something well known only in the UK, because it's called British National Formulary. It's a big book that you found in every clinic room that has all the medicine, all the drugs in the UK. So exhausted the BNF means you tried every drug with him, and you also want to help him. You're distressed as well as a doctor, because you want to help your patient, and that's where the dilemma comes. So why is there a clash that happens between the doctor and the patient about opioids? The patient says to you, I have severe pain. Okay, and he knows that you have a strong medicine. He knows about fentanyl. He read it on the internet. He knows there is oxycodone. Please give me these medicine to help me function. Please take me seriously. Please understand me, doctor. I'm not lying to you. I am in pain. I can't sleep at night. And also, when he asks for opioid, he thinks that you think of him as a drug addict. So they always come and tell you, please, doctor, I'm not a drug addict. I really want this medicine. A bigger picture. There is lack of evidence as well. That's why the doctor don't want to give the medicine. There is lots of side effect that the doctor is thinking about. The patient is not thinking of all of this. You know about addiction, you know about dependence. You need to explain this to the patient. Diversion. You're worried that the patient can take the medicine from you and go and sell it outside in the black market and get lots of money from it. The overdosing, you're worried about this. So you're thinking of things, and the patient is thinking of completely different things. So a discussion needs to happen then. To solve this clash, you have to discuss, you have to listen to the patient first. What is he thinking? And then discuss to him and tell him exactly what you're worried about before planning an opioid. So the tips for best practice, what can we do now? Number one, an exit plan. You tried everything with this patient and you want to give him some opioids. Fine. We will start you on the safest opioids, which is buprenorphine, for a while. And then maybe we can shift to morphine. But what will you do during the opioid time? You have to tell him, you have to put goals, as we said, and you have to advise him to increase his level of physical activity. So if your pain gets better, he shouldn't just lie in bed. You have to do his physiotherapy exercises that he wasn't able to do before the opioids. He needs to stretch. He needs to go out and walk, maybe go to swim. During the opioid time, if his muscles become stronger, then his pain will get better, hopefully. As we said, we do not advise above 120 milligram equivalence morphine, as we mentioned in the equivalent table. Safer alternative first, as we mentioned. Functional gains and time scales. So the patient comes back to my clinic. What did you gain from this short time treatment? Doctor, I'm 30% better. I'm sleeping better. I can walk now for 400 yards compared to 200 yards before I started the medicine. Then it's effective. I will not stop it. Maybe we can increase it even a little bit, because we call this patient opioid responsive, because he responded to the opioids of chronic pain. Let's increase a bit. Yeah, maybe that will help him more, have a better quality of life. Sometimes they come to you and say, doctor, I'm very happy I'm back to work. I'm still in pain, but I'm back to my job. So that's very good. That's a good sign. But you have to, if this is not achieved, you have to consider converting to another opioid if you want, or by starting reducing this. There are many ways of doing this. Maybe we can do it if you're interested. Maybe we can do a lecture about changing from one opioid to another and how we can do this. If responsive, minimize the dose and use sparingly. So as I said, PRN is the best to use at the least effective dose. Some people, unfortunately, keep increasing and increasing and increasing of the dose, but you need to be using the least effective one. Always a single prescriber. If you prescribe it, you have to prescribe the repeat prescription. Don't leave it to anyone else, because you need to monitor the patient, and it has to be one pharmacy as well. But as we said, very careful with other drugs and alcohol. As I said, the end of the lecture is resources. So please go to the British Pain Society and read about opioid for persistent pain, good practice, and opioid for persistent pain, information for patients. If in your practice you want to start prescribing opioids, if you want to know more about this, these are very, very useful tools at the website of the British Pain Society. If you have a pen and paper, please write that down. The other resource as well is the Faculty of Pain Medicine website. It's part of the Royal College of Anaesthetics in the UK. They've put a program in 2018 called Opioid Aware after the crisis in the USA. Very helpful. They write lots of information about how to use the opioids in your clinic, how to prescribe them to the patients. Plenty of information for free for you on this link, please. So if you can also pencil this down to look it up, or come back to the lecture later. So what do we know so far? Opioids are excellent for acute pain. Please use them generously in acute pain. They don't help long-term pain in many patients. There are significant risk and harm associated with long-term use, and we discussed these. Patients many of them who take opioids will be better off. Example, a patient with opioid-induced hyperalgesia, he's in severe pain. You start reducing opioids and giving him an alternative during the reduction, his pain will get better. And we see that a lot in clinic. Education is the most important. You need to know very well about every medicine before prescribing it. Thank you very much. So if there's any questions, we hopefully, I'm not sure if we have any time, because Dr. Zaghloul probably wants to start his lecture now as well.
Thanks, Dr. Ahmed.
Yes, thank you. All finished.
Thanks, Dr. Ahmed, for continue enriching and updating our knowledge in pain and pain management. We have about 7 questions. The first question from Dr. Ibrahim, he asked about locally acting opioid. Is it possible and effective to infiltrate opioid in the surgical incision at the end of surgery or not?
That's a good question. There's no strong evidence on this, but actually, in the UK we use that in acute pain. So there are something called wound pumps. I don't know if you heard about this. So post-operatively, especially in big incisions, like especially abdominal incisions, the surgeon at the end, he inserts a needle connected to a pump. It usually contains a mixture of fentanyl with a low strength of bupivacaine or levobupivacaine. And even we send the patient home with this pump. This pump releases a mixture of fentanyl and local anesthetic around the wound area. And it works like magic, I will tell you. Not every hospital in the UK uses it, because as I said, it's very evidence-based here in this country, but many places, I worked at a hospital called the Royal Free Hospital in London for 2 years, and they were using it routinely for every abdominal incision. So yes, they have a role and they can work.
Thanks, Dr. Ahmed. The next question is from Dr. Ain Al-Marwa. What is the average time needed to be an addict on opioids? The same patient by Dr. Samina Nawaz, opium addiction time.
Okay, so yeah, I mean, we don't know for sure, but if you remember in the lecture when I mentioned dependence, so always dependence happens before addiction. And we said that addiction is a behavioral thing and dependence is the physical. So if the patient comes to your clinic and say, doctor, if I don't take the tablet, if I delay my medicine for 1 or 2 hours, I feel severe headache. My hands start shaking. Then he's starting to develop dependence. You need to be very careful at this level and consider reducing the medicine or replacing it with something else. So we don't know exactly, but the average is between 3 months to 12 months, something like this.
Second question by Dr. Samina Nawaz, are opioids helpful in osteoarthritis and osteoporosis?
Yes and no. So again, opioids are very helpful in any type of musculoskeletal pain. Osteoarthritis is a musculoskeletal problem. The evidence proved that they don't help neuropathic pain very much. So yes, they are very helpful if you give them for a short term with goals as part of an exercise program. So if I have a patient in clinic with severe arthritis and he will have his knee replacement surgery after 6 months, because we have a long waiting list in the UK, I give him strong opioids during these 6 months with a plan to stop it after the surgery. Yes, and they help very well with non-steroidals. Yeah.
I guess it is not a question, but just mentioned in the chat. Patient by Dr. Muhammad Tahan. Patient on chronic opioid, how can we know or differentiate psychoaddiction, tolerance, and induced hyperalgesia clinically?
Okay. Okay, as I said, so you mentioned 3 things. So you want, as I said, if you put a patient on opioid, you have to see him regularly. You can't see the patient and leave him for 3 or 4 months. You have to bring him back, and it has to be one doctor. So if you give the opioid, you have to follow it up. Dependence and addiction, you can detect that by asking him questions. Is he misusing the drug? Is he taking more? Is he taking less? How he looks to you in the clinic, asking him questions about improvement of his pain. Is he meeting the goals you set together at the beginning or not? Opioid-induced hyperalgesia, you can know it by examination. Hypersensitivity is one of the main signs. You find the patient very sensitive even to touch. And he tell you, my pain is worse, doctor, than it was before I started the opioids. Then you need to reduce it and stop it, yeah? Tolerance, it happens with every patient. I don't know a patient that didn't develop some degree of tolerance. He will come after 3 months and say, 10 milligrams is not enough now, doctor. Can you put it up to 20, please? Because it's not working anymore. He's not dependent, he's not addicted, but it stopped working. And we know that this happens. So you need to put up the dose a bit within the safety range. Thank you.
One question by Dr. Muhammad Awad. He asked, do you have any experience in using methadone in UK?
Methadone is used mainly in palliative care. Palliative care is end of life. In the UK, there's something called hospice. So hospice is different from hospital. Hospice is where patients ending life has terminal tumors or COPD, dying, they go into this hospital. Methadone is a very strong painkiller for neuropathic pain, specifically resistant neuropathic pain. And also it's used to withdraw people of heroin, morphine. It's a very effective medicine, but we don't use it regularly in the chronic pain clinic.
There are questions by Dr. Anwar Al-Haq, 3 questions actually. First one by Dr. Anwar, what is the maximum dose of opioid you come across with chronic pain patients in your practice? Okay. The second, do you use opioid medication in neuropathic pain along with gabapentin? The third and last, how do you treat addiction in opioid addict patient? He asked about your algorithm.
Okay, the first question is, sorry, can you say the first question again? Sorry.
What is the maximum dose of opioid you come across with chronic pain patients in your practice?
Okay, I'm glad to say that from 2019, we're seeing less patients because the epidemic that happens in the UK is nothing to compare with the USA. But I saw patients on something like 600, 700 micrograms of fentanyl patches. I saw patients on more than 1,000 milligrams of morphine. And interestingly, I get patients in clinic on mixture of opioids. Some GPs, because general practitioners stop patients on this, give the patient morphine and oxycodone at the same time. And this is completely wrong. There is no evidence of this. You shouldn't be doing this. So we even see mixture of opioids in one patient. So every single person of these, we have to spend many hours with the patient explaining the risk of opioid and put a plan to reduce them. Yeah.
Yeah. The second, do you use opioid medication in neuropathic pain along with gabapentin?
We use them very rarely in severe cases of neuropathic pain that were resistant to every type of other medicine and neuromodulators because they have the least evidence in helping neuropathic pain, but we still use them, yes.
I think that is more than enough question now for Dr. Ahmed Kafafy because we're short of time now, and we would like to start with Dr. Yasser, if you don't mind, because Dr. Kafafy lecture is very wealthy and very precious, and we can go all the night for question and answer, and I know that he's very busy and tight for time.
I'm sorry I took more time than I promised at the beginning.
I understand.
Sorry for this.
Thank you very much. And just only one announcement before Dr. Kafafy leaves us. He is going to participate with us on Saturday, 18th of July, for a small webinar, how to guide for career pathway to UK. And Dr. Kafafy is going to participate how to tailor your career in pain fellowship and pain specialty. And thank you very much to Dr. Kafafy for your lecture tonight. And hopefully we'll meet you again how to sit a pain clinic.
Yeah. Thank you. Thank you, Dr. Saad. Thanks, Dr. Ali, Dr. Ward Ali, and Dr. Hassan as well. Thank you very much.